So we're going to move on now and talk about gastroesophageal cancers. Actually, we'll be talking about GI cancers for the rest of the morning. I think so much happening in gastroesophageal cancers, really so much different than the last couple years. We have Dr. K.S. Kumar. I'm thrilled to have Dr. Kumar come. We worked together at University of Miami a million years ago, but Dr. Kumar is the champion of our chat room. And you've probably heard of a million questions and cases from him, but he comes to almost all our programs and he's always contributing. And I just want to publicly thank you, KS. You add so much to our work. It's awesome. And actually, just to show you what I'm talking about, let's just start with a case. You had this first case, common situation, hear a lot of questions. Yeah, so let's hear what our faculty has to say about it.
This is a 79-year-old gentleman who was found to have occult blood positive stools. He did not have any dysphagic symptoms, and evaluation showed he had a lower esophageal cancer. It was adenocarcinoma T3N1. And we gave him cross regimen, and he had a very good response. Post-therapy PET scan showed a very minimal uptake in the original area, no other disease. And at the conclusion, he refused to have surgery. He has a daughter who has undergone chemotherapy for breast cancer, so he knows about the quality of life. He did not want to go through that, and he wanted to maintain quality of life. So he refused surgery.
Before you go on, I'm just kind of curious. I've heard this story so many times, and in a way, Yelena, it's kind of surprising that somebody would, plan to have surgery and then change their mind. Well, what do you see?
Yeah, what's the histology? Is it squamous or
adenocarcinoma?
Adenocarcinoma. That's an important fork in the road. For squamous cell cancer, it's not that surprising. In fact, often we advise the patients for observation. These are more proximal or mid-thoracic tumors. The surgeries are much more involved, and they have a 50-50 chance of complete response. So often we monitor. For adenocarcinoma, for a young, fit patient, it is a little bit sort of risky to do, but it hasn't not been done with the modern techniques of monitoring, but it's something that we try to advise against.
Well, 79, any major comorbidities?
No major comorbidity, feels fine. He never had any dysphagia. I feel great and eating fine. So he refused to have surgery. Then he asked me, can I have anything else? Can I get more radiation? So the one question I have is, cross regimen used somewhere around 4,170 gray. Most community oncologists give about 5,000 gray radiation, and then they send him for surgery. Is there any issue with that is one question. Two, for residual disease, can you get checkpoint inhibitor? And do you use, or there is no data as far as I understand, if the PD-L1 is like a 50%, would you tempt you to give checkpoint inhibitor at that time?
And what's his PD-1?
5%.
Sam?
Yeah, it's a very common scenario, and I would say in terms of do we have data for consolidation checkpoint inhibitor? Obviously, no. There are several phase 3 trials that are ongoing. But to the first question about radiation dosing, so yes, CROSS was 4140, and the traditional definitive chemoradiation dose is 50.4. So I think a lot of us will hedge on the 50.4 just in case we wind up in this situation where someone has declined surgery or changed their mind, so that we can fall back on the fact that we have given them definitive chemoradiation in the event that they opted not to undergo surgery. There is not really head-to-head data for 4140 versus 50.4. We do have data for 50.4 versus 60, and there was no survival advantage or local control advantage to escalating the radiation dose. That was a trial called Art Deco. So 50.4 is a very common thing. 4140 is also evidence-based. Have we considered additional therapy for someone who declines a surgery? Yeah, it's a common conversation, but I think it is an evidence-free zone. I think in high PD-L1 expression, you can explain it to yourself, but we still don't have evidence for that.
So I got to say, I like the idea of the name Art Deco for a trial. I'm always looking for cool names. I like the Glow trial, et cetera. But anyhow, so I should tell you that the theme of the whole weekend is what you just saw. These are all the people speaking this weekend. which is we want to allow these docs the opportunity to query you. And we've been kind of doing a little humorous thing to sort of emphasize that.
Yeah, great question.
I think it's a very good question.
Yeah, good question, Neil.
It's a great question, Dr. Love.
Yeah, I think that's a great question.
Yeah, it's a great question.
So that's a good question.
So I think it's another good question.
Yeah, so this is a really good question.
I think it's a very good question.
Yeah, good question.
So great question.
Yeah, great question.
Yeah, so it's a great question.
So, I mean, that's a huge question.
Two wonderful questions.
It's an excellent question.
It's a good question.
It's also a reminder of how much we've been able to keep in communication with you. We've been doing, we talk to you all the time now. We're bringing you all. This never happened before. Just to put in perspective, people are new to oncology. We could not do this before. Anyhow, I don't know why we do these things, but there must be a reason somehow. So actually, we want to let Sam talk about checkpoint inhibitors, but how about if I give both of you a couple of minutes, and maybe KS, you can help me, just to kind of paint a broad picture of IOs and upper GI cancers. Let's just say HER2 negative to start with. Histology, PD-1 levels, more of a macro view of how you see that, Yelena. And when the first day of fellows come in, how you explain it to them.
Sure. Well, so in the case that you presented, I mean, the first thought I had, did we test for MSI? Did we test for PD-L1? And satellite instability has really transformed many solid tumors, including upper GI tumors. And in early stage adenocarcinoma, it may be even at a higher rate. For the rest of the patients, so there is probably 20 to 30% of patients that we really make a big impact with immune checkpoint blockade in early stage and metastatic disease. And the rest sort of benefit, but not to the greater degree. So what I tell my fellows is similar to how we give Folfox to pretty much all solid GI tumors. Immunotherapy for upper GI tumors can be used in stage 4 disease, both in HER2 positive and HER2 negative, but the benefit is really in probably 20 to 30% that really, long-term survivors will be alive with disease in 3 to 4 years. So in my opinion, it did transform the field. It's a first step forward, and we're working hard to build on that.
Sam, would you like to add to that? The other issue, again, I know these are so macro issues, but, these docs are dealing with lots of, you saw myeloma, CLL, et cetera. Any way we can kind of make it more straightforward, particularly in terms of, again, histology. It seems like squamous, I know they have higher PD-1s and better responsiveness versus adeno. Anything you want to say about a more macro view of IOs?
Yeah, it is certainly a tool, like any tool we have in the clinic. It has to be weighed risks and benefits. We've all seen severe checkpoint toxicity, so it is a shared decision with our patients. You're right, squames, for the most part, almost every squame is PD-L1 positive. You could argue that the tumor cell staining matters more in squames than in adenos. The bottom line is you have evidence to give checkpoint inhibitor essentially to everybody. That is the labeling for the FDA for most of the approved agents. There is a magnitude of benefit discussion that we have to have with all of our patients, but there is a inertia for us to want to help as much as possible, and there is those patients who have these long-term durable responses. But I do think we have to step back a little bit and ask, where does this patient fit in that spectrum of benefit? Because it's about 20% of patients that will have some toxicity.
So, KS, I'm kind of curious how you view these kinds of things. I think a lot of people are looking for the home run. Once they hear the word checkpoint inhibitor, no matter what disease it is, in their mind there's a possibility. We were talking yesterday, lung cancer, high PD-1, 5-year survival. You see a bunch of people like that. But again, Yelena, is that a reality in upper GI cancers?
It is. It is in a way. I would think about it, again, everything is risk stratification, but right now, I don't have a very reliable way to tell a patient, you will definitely have a long-term survival versus not. I think early assessment with imaging helps. We do have data is that patients who have a partial response or deep partial response actually do fall into that long-term survival category. Certainly doing biomarker testing and so forth. But I don't have you'll hear a case from me today of a patient that we essentially cured with immunotherapy, non-MSI tumor, and it's not someone that, I would love to say that from the beginning, when they first walk in, first or second visit, you will be one of those long-term survivors. And right now, we don't have reliable biomarker data to predict that.
Your patient that you just talked about, KS, that patient had NGS?
NGS, it was negative. He did not have.
And is that adequate to rule out MSI? And does it need to be ruled out in patients with adeno? I guess squamous, no?
I would test everyone. We have this pan-tumor MSI study. We've seen prostate cancer, squamous cell cancer of the skin. MSI can occur anywhere. So if you're a solid tumor oncologist, and for those of you who are generalists in the room, make it easy. Just test as soon as they come in. It says cancer test for MSI, and I would not wait for NGS. I would start with MMR testing. You need 4 unstained slides for 4 mismatch repair protein. And for this patient, I would have tested him even before I recommended chemoradiation. If he's relatively asymptomatic and an R0 resection could have been achieved, and again, complicated social situation, maybe he wouldn't have wanted surgery. But doing chemotherapy potentially is harmful in this patient for an MSI tumor. Unlikely that he's MSI given the high, the PD-L1 and so forth, but possible.
So in that patient, Sam, if he had been MSI high, would you have treated with IO alone? I mean, you're hearing more and more about that. We first heard about that with rectal, but now I'm hearing about it upper GI.
Yeah, it's an emerging paradigm, and actually in August of 2023, the NCCN guidelines adopted this stance that, one, you should test all gastroesophageal, and I completely agree with Dr. Janjigian that we should test every cancer. We do reflexive MMR testing when patients walk in the door. And yeah, if someone is MMR deficient or MSI high in a localized gastroesophageal adenocarcinoma, there is evidence for surgery alone. However, I think increasingly we're all doing neoadjuvant immune checkpoint inhibitor now that we've seen essentially pan-cancer data in the neoadjuvant space.
So IO alone or Ipi-Nivo, Sam?
It's a good question. I have a slide, but there is data for both approaches. There's a trial with Ipi-Nivo followed by adjuvant Nivo that had surgery in it. And then there has been some series with non-operative management. Personally, I think in someone who is older, like this patient, I probably would opt for a single agent PD-1.
So in a second, I'm going to have Sam start with his presentation, but any questions, KS? A lot of people have questions about the flat patients and what to do with them, people who don't respond. Any questions at all for them, KS?
The question is, if the patient, MSI high, already had a surgery, no disease, what do? Do you give checkpoint inhibitor for that patient being MSI high?
So increasingly, and we will publish this soon, for MSI tumors, they actually lend themselves extremely well for ctDNA monitoring. So in a patient like that, I would check Signatera. And if they're negative, they're not going to recur. If they're positive, I would treat them as metastatic disease with immunotherapy.
You say MSI like sheds more?
Just because, if you have so many mutations, you have a high probability of detecting one of them, right? For us, altogether, it would be very hard to sneak out of here, but I could probably just sneak out by myself. So that's the whole analogy between if you only have, a SYN tumor with 1 or 2 mutations and mostly amplifications, it'll be very hard to pick it up. But if you have a lot of mutations, you will, statistically will pick up at least a few.
You guys ever see POLE? We were talking about that yesterday. Never? No. Okay, Sam, let's talk about it.
All right, let's do this. I'm also pretty sneaky, so I could sneak out of here too.
But you're large.
All right, so I'm going to talk about the potential roles for immune checkpoint inhibitors, and I put a lot in here so everyone can have these slides, but I may go a little bit quickly. So all of this starts in the clinic. We're here to take care of patients. So I'll start with the patient that I just saw, which is, I think, something we're seeing increasingly, which is a little bit younger patient. sort of healthy guy, didn't think much of it, presented with a locally advanced GE junction adenocarcinoma. You can see there the clear gastrohepatic node and GE junction mass. This was a mismatch repair intact, underscoring, yes, we test all these patients. I think a missed opportunity sometimes is GE junction cancers. We've been increasingly laparoscopically staging these patients. The data is very good for gastric, but I think sometimes it's hard to localize these, so we will increasingly think about laparoscopic staging. So this is a stage 3 cancer. These are sort of the broad paradigms, and this is the chronic debate of cross versus flot. I just pulled out some of the features of these two seminal trials to compare, but these are the paradigms that we're essentially deciding. You have phase 3 cross trial against surgery alone, when that was the standard, and then you have the flot trial against another triplet regimen when that was a standard at the time. You can see numerically flot is perhaps a little bit better, but comparable. These are slightly different patient populations, but broadly the hazard ratio is similar. Okay, so let's say you gave our patient flot and they still have residual disease. This is a very common scenario I think you've all seen. We all get asked. Patients ask, they come in, they say, but my path's response said I had no response. What do? Do you want to give a cross-resistant therapy? This is evidence to suggest we probably shouldn't give these high-risk patients adjuvant ipi-nivo. This was a trial called Vestige, and this is not what you want to see for your trial. You can see the control arm is the blue arm, and the experimental adjuvant ipi-nivo arm was significantly inferior. And if you look at the numbers, you see the median disease-free survival was 11 months. That's quite short for the ipi-nivo and a little bit more comparable, 24 months in the chemotherapy arm. So the standard, if someone comes in and says, I got flot, but I still have residual disease, the evidence-based answer is still more flot. What if you had given neoadjuvant chemoradiation followed by surgery? This is Checkmate 577, which you have seen. I stratified it out here by histology because that is quite important. You see the difference between the very top and very bottom curves. Those are the squames, and so you can see that the magnitude of benefit is much larger for squamous than adeno, and I highlight the adeno difference there. And what you can see is that the addition of adjuvant nivolumab does improve the recurrence-free survival, almost doubling from 11 to about 20 months. What if your patient was mismatch repair? And this is what Neil just hinted at. So this is a screenshot from the NCCN guidelines that 1, highlights test everybody, 2, think about neoadjuvant immunotherapy, and that these patients often have complete responses to neoadjuvant therapy. In this trial, these patients all had surgery, and when they went to surgery, 60% of them had no disease at all. So there's a very open question, and I think you can have good rationale to think if someone has a complete clinical response, so negative PET scan and an endoscopy with negative biopsies, this is a conversation that we can have about whether non-operative management is reasonable in a mismatch repair deficient cancer. And I personally have done this a few times, but this is the evidence that went into the NCCN guidelines with neoadjuvant ipi-nivo followed by surgery and adjuvant nivo, and you see those curves are outstanding. Well, what about just giving checkpoint inhibitor perioperatively for everyone? So this is early data from Dr. Janjigian's trial, the Matterhorn and Keynote 585 with published. I think the point of this is that putting more therapy in the neoadjuvant space does improve the pathologic complete response rate. You see that here. The question is, does it improve the things that actually matter, which are cures and prolongation of disease-free and recurrence-free survival? And thus far, the answer is no, and 585 was a rather heterogeneous trial with different chemotherapy regimens, et cetera. And so the answer is, right now, we can't justify flot plus nivo or flot plus durva for all patients that come through the door. We're waiting eagerly to see the Matterhorn outcomes. This is just a summary for you showing what was shown in the 585 trials. I won't dwell on this, but what you can see if you look at the very bottom row, the overall survival, 1, we're getting better at taking care of gastric and GE junction cancers. The median overall survival in the main control cohort for flot was not reached, and in the main cohort was almost 60 months. So in the flot original trial, the median overall survival was 50 months. So we're just getting better. We're getting better at taking patients through flot, getting surgery, et cetera. All right, so non-metastatic disease, I think important clinical questions. Do you need a staging lap? As we alluded to, you need to do MMR testing. There is increasing harmonization around FLOT, in my opinion, as the preferred approach for GE junction and gastric and arguably esophageal adenocarcinomas as well. There is not a current role for neoadjuvant or perioperative checkpoint outside of MSI patients. We do have adjuvant data from Checkmate 577. And surgery is quite important for this disease. We really, for the most part, can't get away with curing without surgery, and quality of surgery matters. All right, back to the clinic. So this is your patient. Unfortunately, I think we've all been in this scenario. A few years later, widely metastatic disease. This is not a surgical candidate, not someone who's an oligometastatic paradigm. You did your biomarker testing with standard of care, and you see that this patient has a CPS score of 4. So I made it intentionally 4. I think we're increasingly seeing rationale, and it just adds to the totality of data around this topic. But this was the rationale 305 trial, and basically you can see the point here, which is when you select patients who are more likely to derive the benefit, you see a greater magnitude of benefit. And there you see in the ITT population, the curve doesn't really separate at all until 12 months. And in this greater than 5 population, you see a little bit earlier separation. The tail is the tail. I put this in there as a very recent publication from Dr. Janjigian's follow-up from the Checkmate 649. Same pattern here. This is overall survival in patients more likely to benefit, so CPS greater than 5. You see the curves, they just separate and they stay that way. And if you look at the all randomized, it's maybe in the 6 to 9 months you start to see these pull apart. And unfortunately, the absolute benefit is still in the 2 to 3 month range. And so we're making improvements, and that matters, but it's not where we want to be for our patients. I just want to highlight that other animals have tails too. We see this with targeted therapy trials as well. This is Spotlight and Glow, where you see the tail is actually roughly the same proportion of patients alive at 2 and 3 years as we've seen with immunotherapy trials. This is sort of the take-home that you've probably seen some version of this. These are the PD-L1 strata within Checkmate 649. So if you look as the PD-L1 score increases, the hazard ratio improves. This is just telling us that this is a biomarker. It's not a perfect biomarker, and I don't think it reliably tells us a biology of the cancer, like EGFR mutations, but it does tell you something about the relative benefit of immunotherapy in this patient population. 859 is another trial that adds to this total body of literature. The pattern and the overall themes are the same. As you move up in the CPS strata, we see improvement in outcomes. And then ASCO has weighed in on this, and they're saying basically in PD-L1 negative patients, it's hard to say that we're going to help that patient by adding a checkpoint inhibitor. I think we can all debate about importance of PD-L1 testing and testing multiple lesions and giving all these patients the maximum number of chances. In the 1 to 4, ASCO says maybe, and in the greater than 5, the benefit is very clear. So this has to be a shared decision-making, and this is somewhat divergent from the FDA label, where essentially it's approved independent of PD-L1 testing, although we may see some revisions of that. So 5-FU oxaliplatin is the backbone. You really need to test everyone. We know that we can add immunotherapy, and it does improve survival in some patients. There's a lot of trials that are underway, and we really need to advance our standards. There's a few other nuances I didn't have time to discuss, oligometastatic and peritoneal-directed approaches. Please, we need to do that on the context of a trial.
So a couple of questions, an interesting case coming in from the audience. First, a question to you, Yelena. We were talking, Sam was talking about tislelizumab, and I've seen that there's a slightly different mechanism of action with it. Can you explain what that is? And, it's very hard to compare indirectly, but do you think if there were a difference between checkpoint inhibitors, we would know it at this point?
Yeah, I mean, the survival curves suggest that they behave very similar, and the difference in the mechanism really has to do with the axis of PD-L1, PD-L2, and how they interact. I don't think they're different. And in fact, just seeing all these curves side to side just makes you, it reassures you that there is activity across these agents, and some of these differences in shapes and so forth. The survival curve is really dependent on the patient population that you choose.
So one of the things Yelena is going to talk about is HER2 positive disease. It's been so really interesting to see how that's evolved. But from the real world, we have a case in the audience here.
I'm curious what Sam did for your patient. You never told us.
Yes.
Oh, yeah. What happened?
So we did give this patient chemotherapy plus checkpoint inhibitor for his metastatic disease.
What happened?
Did well. I mean, still on therapy. This is a pretty recent case, so doing well so far. I agree with Dr. Janjigian's point earlier. We tend to do disease response assessments, so I do after usually 4 doses of FOLFOX as the initial scan, and we are incorporating ctDNA, and patients who have ctDNA decreases and early PET response, like, we feel quite good about those people.
All right, so Yelena, here's a case from somebody here in the audience, no man. How do you proceed with a 61-year-old healthy man, dysphagia, diagnosed with distal esophageal adenocarcinoma after EGD, with dilation leading to perforation? PMMR, HER2 positive by IHC, no Mets or lymph nodes or on CT, EUS couldn't be done due to obstructing mass. Do you proceed with A, pre-op chemo given the risk of systemic spread due to the perforation, or chemoradiation therapy?
We don't typically radiate patients with perforation. We wait for the ulcer or whatever to heal. I think in a patient like that, if this was a cardia G-junction tumor, we would absolutely laparoscope them. We would find any sort of concerns for more advanced disease, such as small RP lymph nodes or anything like that. In a patient like this, I would probably give them chemoimmunotherapy plus trastuzumab, because at this point in time, if they're not resectable and advanced, giving them more protracted course of treatment, letting the disease declare itself, and him heal would maximize his chances of cure.
How about IO?
Right, so I would give him probably FOLFOX, trastuzumab, and immunotherapy.
And would it matter what the PD-1 level was?
It would. I mean, increasingly the data suggests that we should select patients even for HER2 positive tumors by PD-L1. Most of them are PD-L1 positive.
So KS, any questions?
The question regarding HER2 positive patients, after initial failure of trastuzumab plus chemotherapy plus or minus checkpoint inhibitor, what do you do? Do you go to trastuzumab deruxtecan, or what is the status of zanidatamab at this point, which is bispecific?
Or, paclitaxel RAM. Sam?
Yeah, I think so. We have a few data sets to pick from. We have the Rainbow trial, which is Taxol and RAM, which did include HER2 positive patients. We have TDXD, which we have a third-line trial and a true second-line trial in Destiny Gastric 01 and 02. And zanidatamab, which is a very interesting drug, the development has really been pushed a little bit more towards the frontline setting with that drug now.
That's a bispecific?
It's a biparatopic, so it actually binds 2 epitopes on HER2, as opposed to a bispecific that would bind like HER2 and HER3, 2 separate antigens. And that's an interesting class of drugs, but very active agent, but certainly not approved. So in the real world, we don't have access to the drug. I think in my own practice, we've increasingly mostly used TDXD in this situation. The response rates are quite high in the high 30s and 40s. Often these patients are symptomatic when they progress, and so response is translated into quality of life improvements. And the data is good. When those patients respond, the median duration of response is good, and the survival is also favorable for them, in the year kind of range. So I've done mostly TDXD in the second line for people post-trastuzumab. We do try to biopsy these patients to understand the evolution of HER2 and the heterogeneity, but in fairness, I think often independent of the biopsy, if we can't get it, we'll still offer TDXD.
Yelena, what's your take on this? And, also the issue of ILD. And if you see a patient who maybe isn't that symptomatic and more stable, are you still going to use TDXD? And if so, how do you screen for ILD?
Mm-hmm. I do stratify by HER2. So if the tumor is HER2 negative, I would probably prioritize either a second-line study or paclitaxel ramucirumab, and then reserve TDXD in third line. Interstitial lung disease, I mean, there's a lot, sort of talk about it. In reality, in our clinic, it's relatively rare because I think overall the amount of TDXD patients get in gastric is just not as high as in breast because of the disease biology. I would just monitor the scans very closely, and I don't generally get any other additional screening. We image these people so often, and so I look at the lung cuts and also read sort of the reports very carefully, because sometimes the radiologist, if they're not aware the patient is on TDXD, they may sort of put the lung findings just in the body and not the impression. And everybody now has something in their lung with COVID and everything. So I think if I see any grade 1 lung changes, stopping TDXD is really the way to go.
And will you re-challenge?
Typically, no, because usually, again, the risk-benefit ratio is not in favor. You know, I've had 1 or 2 patients who've had really like breast cancer level of benefit from TDXD, and with hand holding, with pulmonary PFTs, et cetera, that patient has been on and off TDXD doing great. But that's an unusual situation.
How about HER2 low? And do you all even check FISH?
We do. So the standard is to do IHC first because both TOGA, Keynote 811, and many other studies support that HER2 IHC3+ is the better predictor of durable outcome. And I think it just shows, again, biology, lack of heterogeneity and so forth. And then if they're IHC2+, we FISH. And yes, absolutely, there's a big research program, both with AstraZeneca and Daiichi, looking at TDXD in that population, usually in combination with capecitabine, because capecitabine is the cornerstone of our disease and immune checkpoint blockade.
Interesting. So actually, why don't we go ahead and get some data out, and then we can do some. Any other questions you have, KS?
Not at this point.
All right, let's take a look at some data, and then we'll chat a little bit more.
Sure. So I'm covering the rest of the space. So I'll start with a case, and this is an actual patient in my clinic. You asked me to update the dates, and I know it's been more than 3 years, but I don't know if it was 4 or 5 years at this point. But it's a very characteristic case for 2 reasons. One is because many of these patients present very symptomatic with peritoneal disease, and typically clinical trials exclude those patients because who would want a patient with 25-pound weight loss on their trial? 2 is she's younger than your average gastric patient, and that's unfortunately what we're starting to see in the clinic, increasingly even in non-tertiary cancer centers. And this patient had multiple sort of immune-ish type of baseline findings, like she had type 1 diabetes and vitiligo that you could potentially get, nervous about using immunotherapy. And increasingly, we know how to handle it when she got immunotherapy in first-line setting. So her endoscopy showed an ugly tumor, and she had really peritoneal disease to the point where it was measurable. Again, peritoneal disease often doesn't go on the studies, right, because they have non-measurable or evaluable disease. So as we're writing these studies, we write these patients in increasingly, but she had so much disease that it was clearly measurable. And HER2 was negative. This is what I mentioned. We do routinely by IHC. PD-L1 actually was positive, CPS was 20, and then she was MMR proficient, and then, I put in her NGS, which came out later. We don't wait for it, but we do test it, and she had a sort of a relatively quiet tumor, low TMB, very typical profile for those of you who don't see gastric cancer in the clinic all the time. This is kind of, very quiet, not a lot of mutations.
Could I just ask, I think it's the second time you mentioned that we're seeing more younger people, and of course we've heard about that with colorectal for a while, but is that really a reality for gastroesophageal, and why?
Right, so it's a $1 million question, and I think, Eileen can tell you the same, the trend we're seeing in pancreas cancer and so forth. It's a combination of our vulnerability to external I think, issues, but also things we probably ingest in the environment. I mean, it's, everybody's on everything, supplements, and basically we don't know. We've sequenced those tumors. They don't appear to be biologically different. There's some changes in the microbiome may be different, but there's not a clear point to why.
You have a big microbiome program going on there at Memorial?
We do. I mean, microbiome program is a bit of always like a very broad fishing expedition. Increasingly, it's harder to get funding for those programs because you can't, it's causation versus correlation. But we are pursuing those, we're collecting stool on everyone, again, as part of our young onset center.
All right, let's get back to this patient.
So we did consent her on the study. And she was one of the patients who got randomized to FOLFOX/nivo on Checkmate 649. At this point, I think it was 2018 or 2019. I'm trying to remember. And she got first line treatment. Neuropathy, we kind of got her through, even though she had diabetic neuropathy as well. And then she was maintained on 5-FU nivolumab for a while. What I do for these patients is typically, again, if we see a great response, at 6 months I scope them just to assess the primary tumor because it does help us identify like where the other shoe will drop in terms of clinical progression. And she had negative biopsies repeatedly, resolution of all radiographic disease. At some point per Checkmate 649, we actually stopped nivolumab at 2 years. And now she's on maintenance capecitabine. I don't stop fluoropyrimidines altogether. In her, I could have considered it, but she's very hesitant. So she's getting a sprinkle of capecitabine as a prevention.
There was, at various times over the years, people have talked about looking at exceptional responders to see, studying them more. Is that ever pick anything up on there?
We've, the problem with doing exceptional responders in gastric with immunotherapy is that everybody's getting chemotherapy also. So it could be that she has some, HRD signature that we haven't picked up, and all of this is just chemo, and then we're carrying it through with some exceptional T-cell response. With Nivo-IPI, for example, we do see signatures both on RNA-seq and a whole exome that may predict we call them these vaccinal response, like a vaccine-like response. But with chemo, it's a little messy, and we see the same type of trends. And there'll be a paper coming out on biomarker results of Checkmate 649. But I just wish I had a magic 8-ball so then when imagine to be able to tell a patient that you'll be fine in 5 years.
I was just flashing on before they discovered EGFR mutations in lung cancer.
Yeah.
And they would see these people had incredible responses to gefitinib.
Yeah.
Nobody knew why, and then they found the mutation. They found out why. So maybe someday we'll know why this woman responded.
So another case we can talk about. It's a HER2 positive case, also very typical, and I honestly randomly selected this case. This guy is 45 years old. When he came in, he actually was treated on the original phase 2 that led to the phase 3. He was one of the first patients treated, and again, benefited with complete radiographic response. I took out some of the images just because I didn't have time to show everything, but he had a lot of disease in the lung. That completely went away, and he got pembrolizumab, trastuzumab, and chemotherapy. He subsequently progressed after 2 years in just the primary tumor. The rest of his disease was still a CR. And interestingly, in the primary tumor, his HER2 expression was not as high. We took out the primary tumor, and he was, again, disease-free for some time, and then subsequently recurred. And we have, the pre-treatment and on-treatment changes in his tumor by ctDNA and IMPACT, which is our in-house sequencing panel. And the trends you see is that often whatever you saw at baseline, so EGFR amplification, MYC amplification, things that make the HER2 less of a driver, just increases over time. And in this case, he did maintain his HER2 amplification, and we also were detecting it on ctDNA. So for him, actually, you were talking about MRD setting. We did help use ctDNA to direct his adjuvant stage 4 therapy. So for a long time, we just monitored it before we decided to pull the trigger and treat him. Basically in this case, when he finally did recur, and he recurred in lymph nodes, he got TDXT, and with dose reduction and so forth, Again, it was not an easy regimen for him because he was, he didn't have normal nutrition and stuff, but he tolerated it well.
What was the problem?
Well, so nausea. I don't know for those of you who treat breast cancer, if the breast cancer patients get as much nausea, but this patient, he's a young guy, and young patients just tend to get more nausea, at least in my experience.
We use a severe metagenic protocol, KS, with TDXD?
Yes, we use those anti-immunogenic protocol, and recently I found this olanzapine adding to this tremendously useful.
Yeah.
It also increases the appetite.
Yes.
Is that right?
Yes.
I stopped using Megace and all that. Any appetite patient now, we give them olanzapine. It works great.
How do you talk? Because then they look it up and they're like, "What do you think? You think I'm crazy?" What do you tell them that?
I tell them ahead of time. Don't worry, you're not depressed.
You are crazy.
We're all
Keep going.
okay. So we can start. So biomarker selection. This is not future. It's the reality. HER2, MSI. We used to test EBV much more religiously. I still do but now that immunotherapy is so used commonly, we don't need to know EBV status, but it does predict dramatic response. PD-L1 CPS score using different antibodies. I would say read the fine print when you're getting the results of your PD-L1 testing. I'm still shocked at how often I see TPS in the fine print as opposed to CPS. Some doctors, pathologists who are used to looking at lung, just forget this is different disease. So CPS is the important one, and 80% of your patients will be CPS greater than or equal to 1, and then I think in those patients it's fair game to consider immunotherapy. Claudin inhibitors, that's probably the number one question I get asked. When are we getting claudin inhibitors in the clinic? Hopefully within next few months. It's technically, on track to get FDA approval. There's been, just production issues with the zolbetuximab. FGFR2B overexpression is the sort of newer kid on the block. We are not testing for it routinely yet, but for claudin inhibitor, claudin 18.2, we do test IHC. And then, of course, tumor and plasma sequencing. I think you could learn a lot about for HER2 disease and others, what's going to be the trajectory of your patient's disease. I don't test for ctDNA routinely on all patients, but in HER2 and MSI and select MRD patients, I do find it helpful. For MSI patients, for example, even in stage 4 disease, after 2 years of IO, it's very hard to get them away from immunotherapy. They just don't want to stop because often they come in sick, and having ctDNA at baseline that was clearly high and then cleared helps you coach them through it because if they're ctDNA negative in MSI tumors, they're going to be radiographically okay. So it's been a really exciting trajectory for our disease. After 2010, there was a sort of 11 or so year lull, and now many more approvals are coming. Pharma and small biotechs are really interested in this disease because we've sort of somewhat cracked the biomarker code. So you have to continue to test and so we can learn from each case. So the overlap, there's a lot of talk about it, and we'll talk about it how I prioritize these. The truth is, for most patients, having claudin inhibitors in the clinic is a blessing because they're HER2 negative, low PD-L1, and they're coming in with signet ring cell tumors. So the true overlap between HER2, claudin, and PD-L1 is probably less than 20%. Depending on which data set you look at, it's about 15%. And that's okay. That's why I think AI is not going to be able to take over for us. You need a doctor to prioritize, and we can prioritize together going through some of this data. So how do we prioritize? We look at patient functional status and disease burden. Do you need a response, or do you just need to kind of coast through and make sure the disease is stable? We need to decide the biomarker testing, the therapeutic urgency of starting. Sometimes they come into clinic, even our clinic, with one stained slide. There's no unstained slides, and you may not be able to get them in for an EGD and biopsy quickly for repeat testing. So maybe you just need to act and then add targeted agents later. Adverse event profile, right? If is this an adjuvant setting recurrence where the stomach is out, nausea from claudin inhibitor is not going to be that big of an issue, and you're worried about starting immunotherapy for various reasons, so that would be considered. And then the point is, look at your whole portfolio, right? I start treatment. When I start treatment for this patient, I already map out what am I going to do a second, third, fourth line, fifth line, and so forth. In my clinic, patients get treatment, I interchange what's standard and experimental, what's available to me, and so first line use will be dependent on what I want to give later, and the strategy is key to long-term survival of these patients. We talked about immunotherapy a lot. The crux of the issue is that if you don't use immunotherapy in first-line setting in our disease, you won't get access to it for MSS tumors. There's no second or third line immunotherapy approval. So that's why you have to weigh the risk-benefit and the strategy, because unlike Asia, where nivolumab is used in third-line setting, and that's why they can be a little bit more selective, for us, we don't have access to it. It's only first-line or maybe adjuvant, but not advanced disease. Sam showed you these survival curves. So how do you think about the survival curves? Early and sustained separation, because you don't want to be that patient on the other side of the curve where, at least the blessing is that there's no crossover. And so when you think about the biomarkers, you think about what is the most robust biomarker, and really HER2 is the winner. Even for the outdated TOGA study, there's a clear separation of the survival curves earlier. So is claudin as good of a biomarker as HER2? Probably not. But I think it could be also, maybe zolbetuximab is not as good of an inhibitor as trastuzumab. And claudin is an important biomarker, right, to go forward. And we are exploding that field to the nth degree. Immunotherapy does help shrink tumors. It shows the response as opposed to claudin inhibitors where they just stabilize. There's no improvement in overall response rate in first-line setting. And we know data that shows that if you respond to treatment, you're more likely to be, by response, I mean tumor shrinkage, partial response on RECIST, you're more likely to be one of those long-term survivors. So, and this is the data here, right? So if you're a responder, you will be on that sort of dark blue curve for the Checkmate 649 study, where you want to be. Adverse event profile varies a lot. People talk a lot about immune-related adverse events and worry about that. The truth is most of the side effects from FOLFOX/nivo or immunotherapy of any kind is from chemotherapy. So in Checkmate 649 and the Keynote studies, full doses of chemotherapy were used. I never start with full dose of chemotherapy in your regular cancer patient who's in their 60s, 70s, coming in nutritionally compromised. So I often reduce the 5-FU infusion to 1,000 from 1,200. I drop the 5-FU bolus, I drop the leucovorin bolus, and sometimes I even dose reduce oxaliplatin from the beginning, and patients tolerate it much better. Immune-related adverse events, if they do occur, they occur in the first 3 months typically, so you won't have long-term effects in most patients. But there is a 15% increase in grade 3-4 adverse events, again, mostly from chemotherapy. Zolbetuximab, is a tricky drug because of the nausea. If you have your stomach in place and you have your gastric epithelium, you will have nausea. Patients sometimes get violent nausea during the infusion, and you have to slow down the infusion. And I'm glad you all have experience with Zyprexa because you will need it. You will need all of your tools for antiemetics. These patients get aprepitant, these patients get Dex. And in your regular oncology setting where you don't have a lot of overlap on chair time, to be able to slow down the infusion or even split it between the 2 days, which is what sometimes is needed for claudin inhibitors, will be a challenge. So how do I prioritize biomarkers? It's based on survival, response, and long-term benefit. So absolutely, the king of the biomarkers or the empress is MSI high. HER2 is the next one to prioritize, PD-L1 CPS 5 or greater. So for the top three, you give immunotherapy. It's easy. For HER2, you combine it with trastuzumab, and then Claudin would be the fourth prioritization. Right now, we don't have data to support Claudin inhibition combination with immunotherapy, but if that comes, it certainly will change the prioritization. There's a lot. Claudin inhibitors are coming full force. We have CAR-T, we have engineered monoclonal antibodies, bispecifics, and most importantly, antibody-drug conjugates, so similar to TDXT, but directing Claudin. For HER2, we talked a little bit about the case already, so I'll skim through this. Pembrolizumab, trastuzumab, and chemotherapy improved outcomes. This is the first unprecedented approval based on response rate in the FDA that held up by PFS. And also the EMA approved this regimen in first-line setting because of benefit compared to the TOGA. Before that, lapatinib, trastuzumab, pertuzumab, trastuzumab combinations have failed because in our disease, targeting HER2 just better with better HER2 inhibitors didn't work. We need to combine with other things, and checkpoint inhibitors were the winner. TDXT, you all know well from breast cancer. It has higher drug-to-antibody ratio, and it has irinotecan-like component. And it succeeded when TDM1 failed because it was not sufficient of a bystander effect. Bystander effect is critical in our disease because of heterogeneity, and not every cell of every metastasis will have HER2. So you need to sort of TDXT with a bystander effect. And Sam mentioned the data to you, but we have approval just based on DESTINY-Gastric01. Median OS in that study was really amazing because it was a Japanese, mostly in Taiwanese study. Median OS in third-line setting of 12.5 months. But the data held up based on overall response rate in single-arm phase 2. And so, yes, we use TDXT routinely now in second-line setting. Second-line is probably preferred if HER2-positive is a tumor, just because there are less and less patients. There's a huge attrition in gastric, especially in patients who are not treated in specialized cancer center. So if you don't treat them in second-line, you may not treat them in third-line. They may be too sick. And the future is really combination strategies, and the future of any therapy really to select patients appropriately. ADCs are front and center, both for HER2 positive and HER2 negative disease, for biomarker selection and so forth. Thank you for your attention.
And thank you. We're going to take a quick break now and come back and talk about colorectal cancer.